Sound. Good evening, everybody. Good evening.
Good evening.
This is the time for that webinar that we have been waiting for so long.
Good evening, Dokotela.
Good evening. How are you?
Anor pitching akaralena.
Okay. I want to make you not to be able to be audible. I'm going here. Kanaka. We'll be starting very soon. I see you've got 65 participants. Where do I want to go somewhere where I want you to not be able to be audible. Okay. You can unmute yourself. Right. Thank you. My name is Dr. D T Mahapa. I'm talking here from Polokwane. The topic for today is urinary incontinence in women. Why do I choose this topic? Because anyway, as a urogynecologist, this is the topic, this is the condition that I meet nearly every day of my life. And I think it bothers women so much that we need to make public awareness out there so that people should know that this condition is there and it's treatable, because some of these conditions in our mothers and grandmothers, they become concealed, and being concealed like that, they think it's a taboo to talk about it. So today it's just a public awareness. But before we can talk about this topic, I'd like to tell you that urinary incontinence, or a complaint of involuntary loss of urine, is a debilitating condition of the lower urinary tract. It has got a lot of negative impact on a woman's psychological, mental, and social, even physical well-being. It is more common in women than men. Men rarely get urinary incontinence. They can only get incontinence after radical prostatectomy or after chronic urinary retention. Urologists and urogynecologists are the people that we deal with this on a daily basis. And being so prevalent, I took it upon myself that this month we should discuss it. In the past 10 years, new methods of treating this have been evolving, and now I think we are at the pinnacle of the method of treating this with good results. And before we go further, we must always thank God for giving us the wisdom to come with innovative method of treating this innovative condition. And I thought, as usual, we should start with a hymn. A hymn, and I chose from many hymns, and I thought a hymn from a church which originated in Africa, because this urinary incontinence is, especially in African women, is a hymn that would be appropriate. So I chose the ZCC hymn. Before you go, let's invite the Almighty with this hymn. the hymn that we started with. What is urinary incontinence? Urinary incontinence, by definition, is defined as involuntary or uncontrolled loss of urine from the urinary bladder, which is objectively demonstrable. Sufficient enough to cause two problems. It must be a hygienic problem, or it must be a social problem to the patient. What do I mean when I say objectively demonstrable? It means such that if you go and consult and the doctor fill up your blood and the doctor says cough, strain, or increase intra-abdominal pressure, urine must leak. If it's not objectively demonstrable, it's not urinary incontinence, because more often, once in a while, every woman will once in a while, if he's got a full bladder and increase intra-abdominal pressure, there will be some urine squid in there. That doesn't mean that woman has got urinary incontinence. Urinary incontinence is when it can be demonstrated objectively with a woman with a full bladder in a supine position. You ask her to cough or to strain, urine come out. What do you mean when you say hygienic problem? It must be such that because urine usually smell, or the urine can irritate the thighs and find that you are dirty because of urine. What do you mean when you say it must be a social problem? It might be such that it leads the patient to social isolation. She doesn't go to people because she thinks he might lose urine while she is with other people. If she causes these two problems, then it is the definition of urinary incontinence. What is the pathophysiology? You know, with age, as you grow older, the capacity of the bladder to hold urine decreases. If your bladder, when you are still young, it was holding 600 mils, it will be holding 400 to 300 mils. It becomes smaller. The ability to inhibit urination decline. As you grow older, you can't have a full bladder and postpone it for longer. It's always shorter time. Once your bladder is full, you must make sure that you go to the toilet and empty it at that particular moment. Such that as you grow old, urination becomes difficult to postpone. When you were still students, you could postpone urination for a long time in class, and until the break, then you go and urinate. But the older person cannot do that. And the contractility of the bladder, as you grow older, it gets impaired. Such that when you urinate, you don't urinate all the urine. There's what you call residual volume. Maybe you urinate half of the volume which is in the bladder, because the bladder cannot contract more. That's part of aging. Aging will cause that. The other thing is that with the pathophysiology, let me check something here. That's my Zoom. My Zoom takes 100. I think I'll have to update my Zoom, because I see here I've got 100 participants, which means I'll have to update. Hey, I see here is 100 people and my Zoom takes 100. I think I'll have to upgrade it. And let me apologize to the public. So I'll upgrade it.
Apologize.
Oh, sorry, people. Unfortunately, my Zoom can only take 100 people. And I see you've got 100 people. People are phoning me. I say they cannot enter. I'm sorry. I'll have to upgrade my Zoom. I underestimated my audience. Let's just go with this 100. Physiology. After menopause, in the body, usually in the urogenital system, there is what you call atrophic urethritis. The mucosa of the urethra becomes thinner because of estrogen deficiency of menopause. And as it becomes thinner, the urethral resistance, the length becomes smaller, such that the resistance, the closure pressure, the pressure of the urethra become less, so that when you cough, the pressure inside the bladder exceeds that of inside the urethra. That's why urine comes out. And again, on the pelvic, most people, those who have delivered vaginally, the pelvis becomes lax and the bladder descends downwards. If the bladder descends downwards, you'll see when you explain it later, you lose the that portion of intra-abdominal pressure that you use augment the internal urethral pressure to close the sphincter. And there's a bladder and the urethra have got an angle about 30 degrees, which is called posterior uretrovesical angle. You lose that angle. Once you lose that angle, then it's what you call funneling. The urethra becomes like a funnel. With funneling of the urethra, then it disposes you to incompetence of the urethra and urinary incontinence. Naturally, a woman has got a short urethra, about 4 centimeters in length. You know, in physics, the resistance of any tube is directly proportional to the length of the tube. The longer the tube, the more the resistance. Like a man has got a urethra of about 12 centimeters. A woman has got a urethra of about 4 centimeters. With 4 centimeter urethra, you have less resistance. As I've said, that you lose the posterior uretrovesical angle of inclination with descent of the pelvis and disruption of the pelvic floor because of the loss of that baseline of the bladder where it sits on the pelvic floor. This is just the pathophysiology. When we say lower urinary tract, we're referring to the urethra and the urinary bladder. The ureters and the kidney are upper urinary tract. The function of the lower urinary tract is for store urine and to eliminate urine. Those are two functions. And they're being innervated from the sympathetic and the parasympathetic, plus the motor nerve. The sympathetic are from the thoracic segment 10 to lumbar segment 1. And then the parasympathetic is from segment 2, sacral segment 2 to sacral segment 4. The same sacral segment 3 and sacral segment 4 also come a nerve, pudental nerve, which is somatic nerve. We'll come to that nerve when we came. How do the nerves control micturations? Micturition is controlled in the brain, high in the brain. You can be able to feel that my bladder is full, or you voluntarily go and empty. Or you can feel that my bladder is full, and you voluntarily inhibit urination. The control is in the higher center, in the brain. In the brain, there's a area called periaquital gray matter, which sends the sigmas to the pons. The micturition center in the brain is sitting in the area of the brain called the pons, which, if you want to urinate, the signal will be sent down to the parasympathetic so that you can contract the bladder and urinate. And another signal will be sent through the pudental nerve to tell the external sphincter that is loosened so that urine must come out. But if you want to postpone urination through the sympathetic and hypogastric nerve, you tell the bladder to relax. The bladder, it must relax. It's not time to urinate. But people with urinary incontinence have lost that. Some of them have lost that urinal control, especially with edge urinary incontinence. There are different types of urinary incontinence that I'm going to talk about tonight. Another feature that I wanted to discuss with you is what you call urethral hypermobility. What do you mean by urethral hypermobility? By urethral hypermobility, we mean to say that the urethra, usually it's got its own anatomical position high in the pelvis. If the urethra becomes mobile, it moves downwards. So during the continence, there's a transmission of intra-abdominal pressure to the proximal urethra. The proximal urethra is usually about 1.5 centimeter. It's above the baseline, it's above the pelvic floor. And as you cough, you strain, the part of the intra-abdominal pressure, it squeezes that proximal urethra. That's how it maintains continence. It makes the sphincters strong. But the urethra, this is the part of the urethra that I'm talking about. This is the pelvic floor. About 1 centimeter is inside the pelvic floor. So if the intra-abdominal pressure increases, some of the pressure is transmitted to the pelvis here, the urethra here. Here there's also internal sphincter. So it helps the internal sphincter to keep closed. But if it becomes hypermobile and descends downwards, it becomes like a funnel, and you lose this posterior uretrovesical angle, then there's no, you lose that transmitted pressure that help to augment the internal sphincter, keep it closed. Hence, the urine leaks, incontinence. It can be explained better in this way, urethral hypomobility. So this is urethra, this is abdominal cavity. If this urethra descends downwards because of the effect of pregnancy and childbirth, it's going to be the internal urethral sphincter will be inside the pelvic floor where it's supposed to be the external. And you lose that additional pressure. This additional pressure that you used to augment the sphincter, you lose it. That's why it's happened mostly in women who have delivered vaginally. The prevalence increases with age. The more the person ages, the more the chances that he will have urinary incontinence. But you must hear me clear. Urinary incontinence is not part of normal aging process. It just happens as you grow older. It doesn't mean that if a person is old, he must have urinary incontinence. Usually, these women present very late. That she has got a history of 3 to 4 years of being incontinent. It's now that she's consulting now, or she's being forced to consult now. Because of shame and embarrassment that come with the conditions and the cultural attitude towards genital conditions, our moms and mothers and grandmothers don't discuss genital conditions with everybody. Even with children, they don't discuss it. Even among themselves, they don't discuss it. So such that about 30% in the community, in any community, 30% of elderly women have got some form of urinary incontinence. While in men, it will be half, very few. And I want to tell you that this condition, 90 to 100% of incidents of urinary incontinence can be treated and cured and you remain without a disease. Unlike the myth that says that it cannot be treated, it can be treated. And the people that are out there should tell the grandmothers and mothers that this thing can be treated and you live a normal life without urine leaking all the time when you strain. It is said that in the literature that 25% of women over 65 years, which means menopause, are incontinent. The more older you become, I said, the more incontinent. If you are over 65% in any community, 40% of them over 65, 70, 80 incontinent, which means half of elderly people will be incontinent. More than 50% in a nursing home. Nowadays, we've got what we call nursing homes. More than half of women there are incontinent. And more than majority of them, the reason why they've been taken to a nursing home, they're taken to a nursing home by their own children, their own family, because they are incontinent. They say they smelly urine, it's always dirty, they can't go to places, they're incontinent, take them to a nursing home, which I think is a very bad thing. The World Health Organization has recognized this condition as an international health problem. It happens across all races. And I think the reason for taking women to nursing home because they're incontinent, if it's your mother, your mother-in-law, I think is very bad. I came across this that is written that it is wrong for a Christian family to put a loved one into a nursing home. I think I would say not only Christian family, any family, it is wrong to take your mother or anybody to a nursing home. There's no other reason that can say you take your mother to a nursing home because you are busy, you have been professional. While this profession you got from this same woman, if you are so busy, you wouldn't be able to raise children because children, you can keep them in your house, you can accommodate and look for somebody to look after your children. Why can't you look after people, look after your own mother or grandmother or anybody? There are situations nowadays that people take their own mothers to nursing home. I think I shun upon that. I don't subscribe to that. Because although this condition, it's got an impact on the quality of life of the patient. The lifestyle changes, activities changes because of fear of losing bladder. Hazard is sweating, doesn't go to social clubs. And because of stigmatization, people talking about him that he's smelly urine, he gets embarrassed. This embarrassment leads to social isolation. What she can know, she just sit at home, And more often, because they are old, they're dependent on caregivers. And this urine, as it trickles down the thighs, it causes irritations and is there in the thighs, and such that the woman, because of this embarrassment, it becomes mentally disturbed. That this mental health and physical health, you can even think is not well in the head because of this condition. The economy is a lot. In countries where they look after this, they spend a lot of money on incontinence. And even on herself, because she can't work, she can't do anything, it's got an impact on her own life. There are some stories out there which are myths. They say these people, they present late because it's considered as normal. I don't think it's because they consider it as normal. It's just because of shame and lack of knowledge. They say urinary incontinence and prolapse is natural part of aging. I've said in my opinion that it's not part of normal aging. It's a disease that comes with aging, but it doesn't mean everybody, when you age, you must have prolapse, you must have incontinence. They say that nothing can be done about it. It's not true. And I said that 100% of them can be treated. And surgery is not the only solution. Others are medical, others behavioral. We discuss different methods of treating urinary incontinence as we go out. The problem that compound this is just that embarrassment that leads to silence, and time constraint, which leads to inadequate attention. Usually, physicians and doctors and everybody don't give enough time to this woman to ask them, because consulting an elderly person takes a lot of time, because it takes time to think things, it takes time to undress. They're just in a hurry, so they don't get the full gist of the extent of the disease. And knowledge, limitation in the knowledge of this patient and the pathophysiology lead to the patient accepting that they have to be like that, because my friend next door is always like that. When you go to the old age pension, everybody's like that. So they accept that it's milestone. In places like South Africa, or most rural South Africa, technology and limitation in facilities to investigate this woman lead to inadequate investigation, thus inadequate diagnosis, thus inadequate treatment. And of course, the limitation in resources will also lead to inadequate in treating these women. Let's touch a little bit on anatomy. For you to understand this, you must understand anatomy. The urinary bladder is made of special type of muscles, which are called Drusa muscles. And the portion of the bladder where the urethra come out is called the bladder neck. In the bladder neck, that's where the sphincters are, internal urethral sphincter. A woman bladder capacity, it can accommodate 400 to 600 mL of fluid, of urine, while a man can accommodate up to 800 to 900. A woman's bladder is smaller than a man's bladder. And usually in a woman, the first urge to urinate is at about 300 mL. At about 300 mL, you can feel that my bladder is like, it's got something. If I go to the toilet, something will come out. If it's less than 300, even if you go to the toilet, nothing will come out. And I've said that they're controlled in the center. They're controlled in the pons, where we have seen the pontine micturition center, and the higher cortex, where you can think and say, nice time to urinate, nice time not to urinate. And signals or impulses are transmitted through the spinal cord, the nerves at the parasympathetic and sympathetic. This is the doing of the bladder. This is the transverse section of that special type of muscle, which is called Drusa muscles. And the bladder here, there's an area which is triangular area, which is called bladder trigone. And at the bladder trigone, at the corners, upper corners, is where the urethra enters. It's called urethral orifices. And at the bladder neck here, we have got the internal sphincter. External sphincter is down towards the end of the urethra and the urogenital diaphragm. This is a special type of muscle which can dilate without increasing pressure. I just showed this one to show that if you look at the previous one, from the pelvic floor out of the bladder, there's about 1 to 1.5 centimeter where the extra intra-abdominal pressure will come and augment the urethral pressure. If you look at the man here, that area is occupied by a gland called prostate. That's why a man rarely gets stress incontinent. He rather gets urinary retention rather than to get stress incontinent. Another thing that we must know, every part of the body ages, and the urogenital system also ages. There's what we call urogenital aging. Urogenital aging is a symptom complex with associated physical findings. It involves the lower urinary tract and the genital tract. This aging process subsequently changes the membrane permeability and the neuromuscular junction and function of the person, such that the control of micturition, the control of urination is impaired. Such that if it affects the membrane permeability of the brain, you cannot control the urination from the high center because of degenerative changes that happen with the nerves. Other things that you must understand before you go to is the genitourinary syndrome. There's a condition called genitourinary syndrome, or vulvovaginal atrophy, or urogenital aging. They mean the same thing. This is a broad term that describes a constellation of symptoms that occur in a woman, especially after menopause. It's got three categories: this genitourinary syndrome or vulvovaginal atrophy, or you can call it urogenital aging. There are genital symptoms that occur with aging, which will be vaginal dryness, burning on micturition, and itching. The sexual functioning, which is loss of sensation, loss of orgasm, pain during intercourse, decrease in vaginal lubrication, and vaginal laxity or vaginal stenosis or shortening, depending whether that person is sexually active or not. Then lastly, there are urinary symptoms, which present as urinary incontinence, urinary agency, urinary frequency. Frequency means you go to the toilet more often. During the night, you can wake up 3 to 4 times to go to the toilet. And that's because of short urethra. They've got women at that age, they've got recurrent urinary tract infection. They get easily infected with urinary tract infection. That's why women, they should always have something in their bedroom, urinate during the night, because they've got frequency. But you can keep your blood out throughout the night without going to the toilet. I'm talking about urinary incontinence. There's another form of incontinence which can be self-limiting, can be treated, which is called transient incontinence. It's not a chronic thing. It's caused by different things. Delirium, which is a serious mental change, mental status. People with depression can get transient incontinence. Infections like urinary tract infection can cause incontinence. But if you treat infection, incontinence goes away. Atrophic vaginitis of menopause or arthritis, it can cause incontinence, but if you treat it with hormone replacement therapy, it can go away. Pharmaceutical treatment, some treatment can cause incontinence. Psychological disorders like depression can cause incontinence, but you treat depression, incontinence goes away. Endocrine disorders like diabetes insipidus can cause polyuria, increase in urine production, then it causes incontinence. But you treat diabetes insipidus, you treat incontinence. Restricted mobility. If somebody has got fractures, it's restricted, they cannot move, you'll be incontinent. But if you treat that makes it to be restricted mobility, incontinence will be treated. The mnemonic for transient incontinence is called diapers with double P. That's diapers, how you can remember transient incontinence. Even stool impaction can cause that. What precipitates incontinence? There are external factors. Pregnancy and childbirth is culprit number 1 that causes incontinence, precipitating incontinence. Of course, aging with menopause, loss of estrogen, loss of hormonal fluid will cause that. Trauma, which is non-obstetric trauma or radical surgery from cancer or anything, can also cause that. Or anything that increases intra-abdominal pressure. We'll come to conditions that increase intra-abdominal pressure later. Or drug effects can precipitate incontinence. But I think pregnancy is the commonest culprit culprit number one in the cause of urinary incontinence, more especially stress urinary incontinence. The woman has been pregnant and delivered vaginally, and he lives long enough, as that she will have urinary incontinence one day if he lives long enough. If we look at pregnancy, the hormonal effect of pregnancy softens the ligaments, softens the muscles in preparation for childbirth. And the pressure of the pregnant uterus on the pelvic floor, it lengthens the pelvic floor muscles. Sometimes it tears them. Sometimes it crushes the nerves. It tears the nerves. Sensation becomes impaired because of the nerve injury. And connective tissues and the fascia there become overstretched. There's usually a mechanical disruption of those muscles of the pelvic floor, including the sphincter itself. During birth, there's an incision that's called episiotomy. Whether it's mediolateral or medial episiotomy, it cuts the muscles. And if muscles are cut, usually sutured muscles cannot function the same as unsutured muscles. That also predisposed to incontinence. These are the muscles that I'm talking about. During episiotomy, the one that they're going to cut the bulbous spongiosus, they're going to cut through the perineum. Sometimes they try to use external sphincter. They try to avoid it and go mediolateral. Sometimes you go medial and even cut the anal sphincter so that you have urinary incontinence and anal incontinence at the same time. The stretching of these muscles is by the head of a baby. You can avoid when a baby comes out of the pelvis like this in this animation. The diameter of that baby is the head is about 9 to 10 centimeters, and it stretches those muscles 9 to 10 centimeters. Most people during this process called external rotation. Then when the shoulders, which are wide, passes there, they dilate those muscles so much that when involution occurs after delivery, it doesn't revert back to normal. And with menopause and changing hormonal changes, you get this problem of urinary incontinence. Let's look at the vaginal delivery. I said is the commonest episiotomy and episiotomy. And this is the picture of episiotomy that I can show you. This is a medial episiotomy. This is a mediolateral. It's better to do a mediolateral episiotomy, this one, rather than do a medial, because if you do a medial, if it tears further, it's going to tear the anal sphincter. But if you do mediolateral, you'll spare the patient of the fecal incontinence because you only injure the anal sphincter. The fetal head, as it comes here, it injures these muscles, which are called the pelvic floor muscles and the urogenital diaphragm. The neurological changes that happens with ages and loss of estrogen of menopause, it precipitates the nail on the coffin. If the toilet is not available, like in rural area where toilets are outside a pit latrines, the patient is afraid to go to outside because he's afraid of snakes, or in this day of crime, afraid of crime. There's going to be incontinent, which is a transient incontinence. The muscles of the urethra, because the urinary bladder and the genital system, they occur embryologically from the same area, which is called urogenital sinus. And those, all organs from the urogenital sinus have got high estrogen receptors. So the urinary system, like the genital system, has got estrogen receptors, which makes it to function. Loss of estrogen after menopause will lead to those receptors being dysfunctional and lead to incontinence of urine. What causes intra-abdominal pressure? I said I'll talk about conditions that cause intra-abdominal pressure. Pulmonary disease. A person who coughs all the time. Every time you cough, if you can cough now, you see that pressure in the abdomen increases. Constipation, chronic constipation, because elderly people, they don't have teeth, some of them, they don't chew very well. All the diet itself leads to constipation. They've got chronic constipation. And constipation, when you strain in the toilet, you so much increase the intra-abdominal pressure that you injure the sphincter, you precipitate incontinence. Lifting heavy object, high impact exercises. If we some women with ascites or liver diseases with big abdomens, the pressure in the abdomen is so high that the intra-abdominal pressure will be more than the pressure, the urethral closure pressure, the pressure at which the urethra closes. So if the abdominal pressure is higher than that in the urethra, urine will flow towards the lesser pressure area. People with stroke, there's a transection of impulses from the higher center of the from the pons to the bladder. So the bladder, it just automatically urine comes out because there's no neuronal control. So sometimes when treating urinary incontinence, you got to ask the woman to reduce weight. Although it's very difficult, but ask her to reduce weight. It's very difficult to treat an obese patient. Some medication that can cause urinary incontinence are things like diuretics that increases urine flow. Some antihypertensives in themselves are diuretics. If a woman has got incontinence, has got hypertension and is incontinent, do not treat her with diuretics because you will exacerbate incontinence. Anticholinetics and antipsychotic agents and some antidepressants also, they cause incontinence. Alcohol by itself is a diuretic. You realize that after you've taken alcohol, you go to the toilet more often because alcohol increases urine glomerular filtration, renal filtration of urine. So you urinate a lot. Narcotics and calcium channel blockers, because they are smooth muscle relaxants, they relax the sphincter of the external sphincter such that you become incontinent. I want just to explain to understand urinary incontinence. I've got a podcast that really explains it very well, which I think it's a privilege that
your urinary tract includes the kidneys, ureters, bladder, and urethra. Your kidneys make urine which flows through the ureters to your bladder. Your bladder expands to store urine until you're ready to urinate. Muscles called sphincters contract to hold urine in your bladder. When you urinate, the sphincters relax. This allows urine to pass out of your body through your urethra. Strong pelvic floor muscles support your bladder and other organs so they can work properly. Stress urinary incontinence means urine leaks by accident when movement puts sudden pressure on your bladder. It can happen when you cough, laugh, sneeze, or exercise. Urine can leak if your sphincters or pelvic floor muscles have become weak. Things that can weaken these muscles include childbirth, obesity, aging, and pelvic surgery. To find out more about stress urinary incontinence, talk to your healthcare provider.
Let's classify urinary incontinence. We have got several types of urinary incontinence, but the two that are most important to us as urogynecologists are what we call stress urinary incontinence. The second type of incontinence is called edge urinary incontinence. And the third commonest type is mixed incontinence. Mixed means there is stress incontinence and edge incontinence, the same person. The other category is called continuous incontinence, overflowing incontinence, which is called by neurogenic bladder, the thing that you find in a person who the bladder has lost its control from the brain, from the nerves, like people with stroke. Other incontinence is functional incontinence, which is because the person functionally, if you remember at school, we used to be punished by not going to break. That way you've been restrained. And the child becomes incontinent, which is overflowing incontinence because of the situation in which he finds himself in. Like, for example, if you are sitting with a full bladder, the snake passes by, you get so scared that you become incontinent. That's a functional incontinence. It will go away. There's another one which is called total incontinence or true urinary incontinence, where a person has got vaginal fistula, an opening between the urinary bladder and the vagina, and urine continuously flow through that. We'll discuss that category later. Other incontinence, which of minor importance, is postural incontinence or coital incontinence, where a person who makes love with a full bladder become incontinent. That's not a social problem. It's just that you might just make love with an empty bladder. Or insensible urinary incontinence. Sometimes you find that your pant liner is wet for no apparent reason. But we'll discuss stress and H and the vesicovaginal fistula fully later. I said that the main one that I'm interested in is stress incontinence, which is incontinence that happens when there is increase in intra-abdominal pressure, which is transmitted to the urinary bladder, such that the pressure in the abdomen, which is the pressure in the bladder, exceeds the pressure in the sphincter. If the pressure here exceeds the pressure in the sphincter, urine will come out. Incontinence is a neurological condition. I said that there are two autonomic nervous systems, the sympathetic and the parasympathetic. The sympathetic tells the bladder that do not contract, relax. The parasympathetic tells the bladder that now it's time to urinate, we can contract. If there's parasympathetic hyperactivity for the sympathetic, it will tell the bladder to contract and expel urine in times or situation where it's not appropriate to expel the urine. Or we can say this bladder has lost control of the higher centers. It just contract spontaneously. Overflow incontinence is that type of functional incontinence that we have. If, like I gave an example of a child who has been punished for not going to the toilet. The urine will, or somebody who cannot move because he's fractured, or is an elderly person, he needs help to go to the toilet, he needs aid to go to the toilet, and there's nobody to help her. The bladder will be overfull such that the pressure in the bladder will ultimately exceed the pressure in the sphincter and incontinence will occur. These are the commonest type of incontinence that we find in the elderly. So stress urinary incontinence by definition is involuntary leakage of urine on stress. Stress, I mean sneezing, coughing, laughing, running. It's the most common form of incontinence in the elderly. Although it can happen in the young ones, but it's mostly common in the elderly because of that hypermobility of the urethra that I told you, loss of that additional intra-abdominal pressure on the proximal urethra, that loss of a posterior urethrovesical ankle. You see there's an ankle here. With urethral hypermobility, you lose the ankle, posterior urethral ankle, and the urethra becomes like a funnel. You've got funneling of the urethra as opposed to here. That urine pressure is transmitted here easily and you lose urine in that way. The common symptoms that the woman will come with incontinence, you have to listen carefully. She will come just complaining of frequency of urination. I go to the toilet 10 times a day. During the night, I can wake up 5 times. Or she has to wake up during the night to go and urinate. Or because of short urethra and increasing the prevalence of having urinary tract infection, she will come with painful urination or burning on maturation. And she will tell that she has got double voiding. When she goes to urinate, she will urinate. If she waits again and tries to urinate again, another urine will come again because of incomplete emptying with what we call increased residual bladder volume. Or sometimes they'll just volunteer incontinence, or there's an irresistible urge to urinate that once she can say she must urinate, the bladder is full, she must go and urinate now. Otherwise, the bladder is going to release. Or she might complain because it's old, or because of atrophic vaginitis, she might present of painful sex or prolapse or other things. But majority of women who present with this have got urinary incontinence. But urinary stress incontinence is the commonest incontinence in women, especially elderly women. They lose urine easily with increased intra-abdominal pressure because of damage in the pelvic floor, pelvic sphincter, which is caused by pregnancy and childbirth. They present of this symptoms of loss of urine when they cough, when they laugh, when they squeeze, when they rat, when they live, even when they're walking. They lose urine. I want to animate to stress incontinence so that you can understand it very well.
Stress urinary incontinence in women. Urine is produced in the kidneys and stored in the urinary bladder. Urination is the process of emptying the bladder through the urethra that connects the urinary bladder to the external urethral orifice. There are two sphincters, or valves, that keep the urethra closed to prevent leak. Internal urethral sphincter, located at the neck of the bladder, and external urethral sphincter, located right above the external urethral orifice and is supported by the pelvic floor muscles. When the bladder is full, stretch receptors in the wall of the bladder send a signal to the spinal cord and the brain. At times when it's not appropriate to urinate, the brain sends back an inhibitory signal to keep the sphincters closed and prevent voiding. When you wish to urinate, this inhibition is removed. The spinal cord instructs the muscle of the bladder, the detrusor muscle, to contract and the sphincters to open to let the urine out. In stress incontinence, small amounts of urine leaks when the person is sneezing, coughing, laughing, or having any activity that creates abdominal pressure on the bladder. This usually occurs because the pelvic floor muscles are weakened and can no longer support the sphincters. In women, this typically happens as a result of pregnancy, childbirth during which these muscles are overstretched. In most cases, this condition can be treated with exercises that strengthen pelvic floor muscles.
This is how to explain, just to explain to you what stress incontinence is. Another form of incontinence, which is called urgency incontinence, some people call it detrusor instability. I said the detrusor is the type of muscle that the urinary bladder has. That special type of muscle is called detrusor muscle. Detrusor instability is another form of incontinence, which some people call it unstable bladder. Uncontrolled spontaneous bladder contraction. Bladder just contract. You're just sitting with the people, suddenly the bladder just contracted and all urine comes out. Sometimes the bladder contracts while you are trying to inhibit urination, contracts itself. Such a person, if he can feel that the bladder is full and she wants to go to the toilet, she must go now. And the more she goes toward the toilet, the more they urge to urinate. And sometimes they lose urine just on the doorstep of the toilet. That's the detrusor instability, because the detrusor, there's increase in parasympathetic overstimulation over the sympathetic inhibition. There's what you call bladder dyssynergia. There's no synergy between the nervous system that says the bladder contract and the one that says contract. There's no synergy between that. So that's why they call it bladder instability, as opposed to a neurogenic bladder. Neurogenic bladder is a bladder that has got no neurological impulses, like people with spinal cord injury. There's no impulse going there. The bladder just fills up and fills up until it becomes overflow. This type of incontinence you find in people with stroke. The detrusor instability. This is how to demonstrate.
Urge incontinence, also known as overactive bladder, that sudden overpowering urge to use the bathroom, happens when the detrusor muscle, which surrounds the bladder, experiences spasms or contractions when it isn't supposed to.
It just experiences spasm and contraction when it's not supposed to do though. So with edge, that type of incontinence is called edge incontinence, which means you've got an edge to urinate. You've got irresistible edge to urinate. If you have to go, you must go. And also, because of this urinary bladder spasm, the patient complains of the urgency. If he has got to urinate, it becomes urgent. Sometimes they don't reach the toilet in time. More often, I picked it like this. The more you open the toilet, by the time you sit there, urine is already trickling because of the urgency of urination. That's the type of urination that also incontinence that is also found in the elderly, but it's not as common as stress incontinence. Mixed incontinence, I said, is a mixture of stress and age incontinence. And for you to determine which one is the predominant form of incontinence, you've got to do a test called urodynamic testing, which they use instrument to measure the intra-abdominal pressure, intravesical pressure, intraurethral pressure, and do mathematical calculation there to tell which one is the predominant in incontinence. Because when you treat, you must treat the predominant incontinence first. You mustn't treat the stress and exacerbate age incontinence. Functional incontinence, I said, is a classification that is mostly in the elderly because of urinary tract infection and restricted mobility. If they have restricted mobility, they'll have aneurysms, they'll have bedwetting. They are not bedwetting because like children. It's because for them to stand up, they need somebody to help, but there's nobody help. So she wets on the blankets. Some medication like diuretics also can cause functional incontinence. There are some form of unusual causes of urinary incontinence, like urethral diverticulum, which is an outpocketing on the length of the urethra, which can contain urine. After you finish urinating, then when you stand up, that urine in the diverticulum will trickle out. That woman will always put a panty liner there so that she knows that after I've urinated, if I move out of here, there's going to be a trickling of urine. Some people with urinary fistula, which we'll discuss later, they have got total incontinence. I say it's unusual cause because it used to be unusual. And in South Africa, it's becoming usual now. It used to be usual a long time, I think, what they say. But during our time when we were young and when we were training, you will rarely see genital urinary fistula obstetrical cause. But nowadays, I see it's coming. And congenital abnormalities of the bladder also, they are very rare. Let's discuss urethral diverticulum, which causes a rare form of urinary incontinence. It's a condition where diverticulum is a condition where there's abnormal or pocket or a sac along the length of the urethra. Like you see, this is the length of the urethra. Along the length, there's a pocket here. Urine, as it comes out here through the urethra, some will collect in here. And the sphincter is beyond the sphincter. As the patient stands up from the toilet and walk, then that urine which is in the diverticulum will trickle out. That's the urethral diverticulum. Investigate the urethral diverticulum, you can suspect it, but good diagnosis is done by X-ray, which is called urethral imaging by an eye. Then you can see a diverticulum visible there along the length of the urethra. If you do a cystourethrogram, then you see an outpocket in there, then it's a diverticulum. Then can be treated. The treatment of diverticulum is always surgery. Sometimes, if you suspect it's a congenital thing, you can do an intravenous pyelogram, which can put a dye which delineate the upper urinary tract from the kidney up to urethra, up to the bladder, up to the urethra. Kidney, ureter, bladder, up to urethra. The full renal system investigation. One of the investigations that you have to do if a person has got urinary incontinence, most people in elderly. I said that they don't urinate because of poor bladder function. As you grow old, the ability of the bladder to contract diminishes. They have got what we call increased residual volume. When they urinate, they don't urinate all the urine. Most of the urine remain inside. And that's urine inside. If it gets infected by bacteria, that's what causes chronic persistent urinary tract infection. And you can test let's show you. If the bladder is full, you urinate, you find that a certain percentage remains inside always. And this residual volume can increase all the time. And you can measure it either by ultrasound or by catheterization and measure it. You can measure it, I said, by doing ultrasound. You measure by the volume of ultrasound, usually 3D, or you catheterize and measure that volume. If the volume is less than 50 mils, it's considered normal. A residual volume of less than 50 mils is normal. But if it's less than 200, it's too much. And there's an intermediate range between 50 and 199, which need to be determined depending on clinically whether this is significant or not. The history, usually the patient will tell you a lot, even the physical examination and analysis of urine. But post-voiding residual volume, if indicated there's symptoms of complete empty, look for diabetes mellitus. Look for history of urinary retention. Look for drugs that he's taking. Or then can be because of prolapse, usually a cystocele, or previous continence surgery, which has increased the urethral closure pressure so much that when she urinates, the bladder cannot empty more than 80% of its content. They usually focus mostly on medical history and neurological history. As I said, the medical condition can give a patient that. The voiding pattern, the patient given a voiding diary, must tell her, what's a voiding pattern? There are people who have voiding pattern. They just don't go to toilet. And we will review the treatment that she's taking. Elderly people usually are on polypharmacy. They are either treated for diabetes, hypertension, arthritis, this and that condition, and duration. And monitor that. If you think one of the drugs that is there is interfering with is precipitating incontinence, change it to a better drug. There's always an alternative drug. And of course, general examination of the patient is also will give you a clue what the condition will be. Always urine must be examined, whether it's burning or it's not burning. If it's got glycosuria, diabetes must be suspected. If it's got pyuria, infection must be suspected. If you've got blood, suspect cancerous conditions. If you've got nitrites, infection must be suspected. How do you manage urinary incontinence? There are three categories of management. Behavioral, you can manage that by behavior, teaching the patients how to behave with it. Urinate frequently, or pharmacological. Usually, stage incontinence treatment is pharmacological. Tablets, treatments, drugs. Or surgical, you can treat it surgical. Usually, stress incontinence treatment is surgical. Non-surgical usually is stress for patients who do not want surgery, or where surgery is somehow contraindicated. But this woman is 90-year-old, surgery itself will be too much for her. She can't stand anesthesia. You postpone surgery and go behavioral or pharmacological. But if it's stress incontinence, can only be behavioral. Pharmacological doesn't work for stress incontinence. Pharmacologically, it works in this way. Estrogen is a female hormone, and decrease in estrogen leads to decrease in urethral resistance and urethral closure pressure, which leads to escape of urine during maneuver that increases intra-abdominal pressure. That maneuver, I mean lifting, laughing, coughing, and etc. Such that the intra-abdominal pressure exceeds the urethral closure pressure. In menopause, the estrogen contributes 30% of the closure pressure. So if after menopause you lose 30% of the closure pressure, you predispose yourself to incontinence. Estrogen treatment or replacement is good for mild to moderate stress in urinary incontinence, but not severe one. And it can be administered vaginally as a vaginal cream or as an oral treatment. Estrogen, it helps in the obstruction of urine flow by restoring the mucosal thickness. And the blood vessels that surround the urethra, they also form a cushion which augment the pressure on the urethral closure pressure on the internal sphincter and the muscle integrity of the urethra. Thickness and hypertrophy of the urethra, that's what's going to cause the closure. Treatment like anticholinergic and adrenergic stimulant, they control the spasticity of the bladder. That bladder that contracts with spasm, they abolish that spasm. Then you treat incontinence that way. Calcium blockers by themselves, they block the calcium channels. They are smooth muscle relaxants and also striated muscle relaxants. So they help on the detrusor, relax the detrusor. This is some of the, not all of them, some of the pharmacological management common in the treatment of stress incontinence. You can use the antispasmodic, which will reduce the spasm of the urethra, or an antagonist of the muscarinic receptors like terperidine, or antispasmodic like Urispas, or a tricyclic antidepressant like imipramine, or muscarinic receptor agonist like Vesicare, or 3-alpha adrenoreceptor agonists like Betmiga. There are many, the list is endless. There are many treatments. You give this one, it responds well. To the second one, the same patient doesn't respond well. You have got to juggle around and see which patient responds to which one. What is behavioral management? Behavioral management is patient education. You teach the patient to have scheduled voiding. You must actually put a watch and say, after every 2 hours, I must go and urinate. Otherwise, I'm going to have incontinence. You must put positive reinforcement. Reward her if she can spend 2-3 days without being continent, to encourage her to stick to that routine of scheduled voiding, scheduled going to the toilet. Don't shout at the patient who has weed on herself. We're making her worse. Encourage her, say, Mom, I'm tired of happy. That's good. She gets positively reinforcement. An elderly person behaves like a small child. He responds very well to positive reinforcement. Of course, pelvic floor exercises help in the perimenopausal. The very old elderly doesn't help as such because some of the exercises are too much for a very elderly. If there's a caregiver, I don't mean at the old age home. At home, you are the caregiver. A scheduled toileting. Remind her, go to toilet. Before she goes, even during the night, wake her up. Like you used to teach a child. If you've got a child who's bedwetting, you used to wake up at 3 a.m. and say, go and urinate. Do the same with this person. Teach a habit of, train a certain habit of waiting. Or prompt waiting, there must be something that prompts you. Nowadays, with cell phones and everything, you can put a timer there, which every 3 hours it can ring. It knows that this is the time to go and urinate. She goes and urinate. When I say pelvic floor muscle exercise, which I said it's not for the very elderly, they're usually very good after delivery and after birth to avoid future stress urinary incontinence. Immediately after the muscle has been overstretched, do pelvic floor muscle exercise, which is called Kegel exercise, which is named after Arnold Kegel, who described this in 1940. It restores continence by strengthening the pelvic floor and the periurethral muscles. And these muscles, only muscles around the urethra, it concentrates mostly on the muscles around the urethra, the pelvic floor muscles, the levator ani muscles, the urogenital diaphragm, the sphincter urethrae, sphincter vaginae, and all those muscles. This exercise, they strengthen those muscles. The benefit is that it eases the menopausal symptoms. It provides the pelvic floor muscle and support for various organs. And after delivery, as I've said, vaginal delivery, it disrupts the pelvic floor. Exercises, it prevents involuntary loss of urine by restoring the functionality of that muscles. And there are different shapes of exercise that you can do. Physiotherapists are very good at that. Sometimes you can lie down here and increase the abdominal muscles. There are different types. You need to go to a physiotherapy to teach you how to do pelvic floor exercise. I'll just give you a clue of
relax the muscles of your thighs, buttocks, and tummy. Lift and draw up the pelvic floor muscles around your urethra, vagina, and anus at the same time, as if trying to stop the flow of urine and wind. As you lift and tighten your pelvic floor muscles, there should be a feeling of lift each time the muscles are squeezed. Hold your muscles strong and tight for 3 to 8 seconds. Then let go and relax. There should be a distinct feeling of letting go. Repeat the lift, tightening and letting go of your pelvic floor muscles 8 to 10 times. Relax them.
These are the pelvic floor muscles. Another behavioral management is that restrict fluid. Not to say she mustn't drink water, she must drink 1.5 to 2 liters per day, but reduce fluid before going to bed. Usually fluid like coffee and alcohol, the caffeine is an antidiuretic. And bladder retraining. By bladder retraining is that you retrain the bladder to accommodate more fluid. If you feel that the bladder is full, let them postpone it by 5 minutes, next time 10 minutes, so that the bladder capacity can increase. As I said in the beginning, that as you grow old, the bladder capacity diminishes. Or you can put a pessary there, which helps, well, it can help reduce pelvic organ prolapse. And it can also augment the urethral closure pressure. If you've got there are different types of pessary, Hodge pessary, you've got ring pessaries, different types of pessary. The one that fits very well, which I find it fitting very well, is the ring pessary. The pessary support and correct the prolapse, and it holds the bladder up. By holding the bladder up like that, you see the ring pessary sitting like this here on the urethra. It impinges on the anterior vaginal wall and increases the urethral closure pressure here at the level of the internal urethral sphincter. So it helps the internal urethral sphincter, while on the other hand, it supports the prolapse. Fluid management, I've said that avoid fluid at certain times, especially going to bed. Avoid alcohol, but drink water. The elderly people must drink water 1.5 to 2 liters per day, because if you don't drink water, urine becomes concentrated. And the concentrated urine also irritates the bladder, will lead to incontinence of urine. Bladder training, you avoid by the clock. I said these days with cell phone, you can put a timer there. And gradually increases the interval between the voids, or by double voiding, so that you must reduce the post-voiding residual volume. The physiotherapist, if you've got opportunity to go to them, they'll do pelvic floor exercises and teach you how to do them and strengthen those muscles. And sometimes they use instruments like vaginal cones. They put a cone in the vagina here, which increases the strength here and train this muscle to be stronger. Physiotherapists in treatment of incontinence are very important. Hormone replacement, whether systemic or locally, it is estrogen replacement. Its job is to increase the thickness of the urethral mucosa. If there's estrogen deficiency, urethral mucosa is thin. But if there is hormone replacement therapy, it becomes thick and rugerous, such that the pressure in this rugerous thick mucosa is higher than a thin atrophic mucosa. So hormone replacement therapy does help. Another way that you should do, especially very old women, is use of diapers. Yes. In very old and frail women, they can't do pelvic floor exercise, they can't do anything. If they've got stress incontinence, they've got other comorbidities, other diseases, and they can't do surgery because they are themselves are anesthetic risk, the surgery will kill them. So what do you do for a woman who's got occasional incontinence? Occasional incontinence means she doesn't have incontinence, but occasionally she does lose urine. If he goes somewhere, she knows that I'm going to a wedding or somewhere, she can use diapers in case he doesn't lose urine there. And diapers these days, they come, diapers like pad like this one can absorb almost 400 mils of fluid without being visible. So they are very good. Nowadays, they're designed in a very good design. Sometimes it can be like a pill. This is a diaper on itself. Here is a pad which can absorb more than half a liter of fluid without tickling it out, without even showing smell. Very elderly buy them diapers. Sometimes incontinence is so bad that you need to catheterize the patient all the time, more especially if you've got total incontinence. or she has got stroke, she's bedridden, or neurogenic bladder, she might need continuous catheterization, which can be urethral or suprapubic catheterization. With continuous catheterization, a person can even go to social gatherings because there's one nowadays, the catheter that you can put in the bladder for a long time, for more than a week, and the urine bag you tie it on they call it a leg bag on the leg, and she puts on a maxi dress. Nobody can see that there's urine bag there with drains urine, and she can go to the shop and go anywhere with that continuous drainage through the bladder. In extreme cases, really patient with cancers or patient with fistulas that have failed correction, you can do diversion. You divert the urine. Urine mustn't go towards the bladder anymore. You divert it. The two common type of diversion are Brigger's operation, which is called ileal conduit. In Brigger's operation, they take a part of terminal ileum and like a colostomy, they put it out through the lateral abdominal wall and put a stoma bag there and implant the ureter on that ileum so that the urine can be diverted to that ileum. It doesn't go to the bladder. Even the patient with bladder of the cancer of the bladder will do that. Another common one is Mitrofanov procedure. Mitrofanov procedure, it does differ slightly with Brigger's operation, is that they take the ileocecal junction where there is an appendix with its blood supply and dissect it from the entire colon, the alimentary system, and make an artificial bladder with that. And they use the appendix as a stoma on the abdominal wall, and the patient will continuously, intermittently catheterize the appendix to empty that. This is what we call Brigger's operation, ileal conduit. This is part of the intestine. They take it through the umbilicus. The ureters, they take them and implant them there. It doesn't go to the bladder. This patient probably has bladder cancer or VF that's irreparable. So the urine is diverted. Or with Mitrofanov, it takes the ileocecal junction, dissect it away from the entire alimentary system and make an artificial bladder with that. And the appendix, they take it out here as a stoma, and the patient can intermittently catheterize herself. That's in extreme cases, mostly done for oncology patients with cancers. The common surgery that we do these days is bladder neck elevation surgery, which correlates very well with the pathophysiology. Historically, they used to do anterior colporaphy with Kelly Kennedy modification. This is falling out of fashion because of the failure rate, but it does help, but it's not as good as others. Then came the three procedures which competed for a long time: West Colpo suspension repair, Marshall machete crans repair, and Richardson paravaginal repair. These are all called retropubic urethropexy repair. They competed a lot, and literature says this one is better than this one is better than this. I can just say there's no one which is better than anyone. In surgery, it's as good as the hands that's doing it. It depends who does it. Surgeon A might be good at colpo suspension, but bad at paravaginal repair. And surgeon B might be good at this one and that one. There's no surgeon which is better than the other. It's a surgeon who is better than the other one. But nowadays, they were surpassed by sling operation, which are less invasive and patient vaginal, which sometimes they compete with needle suspension. The bulking agents has got their place reserved, but they're not as good as sling operation, but we'll discuss them a little bit. This is the picture of you showing the colpo suspension, retropubic urethropexy. With batch colpo suspension, the vagina at the paravaginal area is attached to the Cooper's ligament on the upper surface of the superior pubic ramus. With Richardson, the same area is attached to acostendinous facial lata, the white line. While with Marshall machete crans, the same area is attached to the anterior abdominal wall. It doesn't matter of where you attach it, but the pathophysiology is the same with retropubic erythroplexis. Semi-needle suspension is getting, urologists like it very much, particularly for male incontinence. But transvaginal tape like TVTO or TVT suprapubic, they are very popular now, and they're short, less invasive, very good results with them. I want to show you the difference between transvaginal tape retropubic and transvaginal tape obturator. The dynamics is the same, but the methods of inserting the mesh differ. You look at this instance-free transvaginal tape retropubic, as I demonstrated in this webinar. It doesn't play, okay? Okay, I'll play it like this. There's always with computers.
If you have stress urinary incontinence, your doctor may advise you to have a tension-free vaginal tape or TVT procedure. Stress urinary incontinence means your bladder leaks urine during physical activity. To start the procedure, the surgeon will make 2 small incisions in your abdomen just above your pubic bone. Another small incision will be made in your vagina. A needle will be passed through this incision into your body and out of one of the incisions in your abdomen. A mesh tape attached to the needle will be pulled along this path. Then, a needle attached to the other end of the tape will repeat this procedure on the other side. Once the tape is in place, your surgeon will adjust it around your urethra to provide support. The ends of the tape will be cut just beneath your skin. At the end of the procedure, the vaginal incision will be closed with sutures, and the pubic incisions may be closed with surgical glue or sutures. After the procedure, the tape will support your urethra and prevent urine leakage. Over time, scar tissue forms around the tape to hold it in place. To find out more about a tension-free vaginal tape procedure, talk to your healthcare provider.
Now look at the difference between what you have seen now as tension-free vaginal tape retropubic. Look at the difference between that one and the TVTO.
If you have stress urinary incontinence, your doctor may advise you to have a transobturator tape or TOT procedure.
Transobturator.
Stress urinary incontinence means your bladder leaks urine during physical activity. To start the procedure, the surgeon will make 2 small incisions in your groin. Another small incision will be made in your vagina. A needle will be passed through this incision into your body and out of one of the incisions in your groin. A mesh tape attached to the needle will be pulled along this path. Then, a needle attached to the other end of the tape will repeat this procedure on the other side. Once the tape is in place, your surgeon will adjust it behind your urethra to provide support. The ends of the tape will be cut just beneath your skin. At the end of the procedure, the vaginal incision will be closed with sutures, and the groin incisions may be closed with skin glue or sutures. After the procedure, the tape will support your urethra and prevent urine leakage. Over time, scar tissue forms around the tape to hold the tape in place. To find out more about a
These are the 2 types of tapes that I personally use, and I find them very user-friendly, and I've got good success rate. As I said, the other one is retropubic, but the aim is to hold the urethra up in the abdomen, in the pelvic cavity. You can see both TVT, retropubic, and TVTO, they all go around the urethra and do the same thing. It that depends where you attach the ends. Another one ends is attached on the abdominal wall, another one is through the obturator foramen on the thigh. But they do more or less the same function, which is to hold the urethra up, increase the posterior urethrovesical angle, increase the intraurethral pressure. These are the other types of DVTs which have fallen out of the market, is like DVT Brave and Secure. They were less invasive, but the literature showed that they were not much popular in treating stress urinary incontinence. Now we have got an emergence of third world urinary incontinence coming to South Africa. It used not to be there when we were training and when we were growing, but it's coming back. It used to be there long ago in the medieval. Incontinence that come because of prolonged labor, prolonged several pelvic disproportion. A woman doesn't get any help for 12 to 24 hours with the head stuck there, and it compresses the bladder against the posterior surface of the symphysis pubis, and the woman gets pressure necrosis there, and she later develop what you call vesicovaginal fistula. If I tell that this thing was not there, I trained throughout my residency 4 years. I've never seen it. I didn't know how to do it by the time I qualified, because they were not patients with such diseases. Where a woman goes into labor and the baby, the head cannot come here, and she suffers for more than 12 hours without getting help, it was not heard of. There would be an ambulance taking him to the hospital for Caesar or something. These days, it does happen. It does happen. Before the ambulance, it's not there, and everything. A woman sit there behind the mountain, and the head is compressed against the symphysis pubis. The bladder gets pressure necrosis, and he gets vesicovaginal fistula. This is the mechanism. If this head is pressed against this bone of the symphysis, there won't be blood flow in the area there. And if that blood flow is not there for hours, that area will undergo what is called ischemic necrosis. It will die. Cells will die there. And if these cells die, after some time, the dead cells will slough off. There will be a hole between urinary bladder and the vagina. And that's what we call vesicovaginal fistula, VVF. It's coming. It used to be not there. It's coming. I didn't know how to do it. Until now, I learned it now when I'm already working that patients are coming. Now I had to learn how to do VF at my age. It's said that 2 million women in Africa are living with VVF. In the whole world, 2 million. 90% of them are in Africa. In Nigeria alone, there are about 12,000 cases of vesicovaginal fistula from prolonged labor, unattended labor, poor healthcare planning, women a year, which means if you divide it, is about 230 women per week in Nigeria develop VVF. What about South Africa? We are going towards Nigeria. Our health system will be as bad as the one in Nigeria. We are going there because we just see emergence of VVF. You know, when we were training, it was not to hear about mutu, which means somebody died while delivering. Now, our maternal mortality is becoming higher and higher because women are not getting help. When she happened to land in a clinic remote and such that she cannot deliver, such that she needs a cesarean section urgently, she might sit there if she doesn't have her own transport before she can reach a place where she can be helped. This is exacerbated, this VVF is exacerbated by shortage of midwives, closure of nursing colleges. You know, when we took over government, we closed nursing colleges. I don't know what was the motive behind closing nursing colleges. And now, because of crime, clinics don't deliver 24 hours. So if a woman is in the clinic and the sun set while she's there before she's delivered, she must be transferred somewhere. And if there's no transport, then there's no help. That's how VVF comes. This is all because of poor health care. I worked in Limpopo and worked in Gauteng. I'm a witness. I know what's poor health planning. I've seen it happen in front of my eyes in the two provinces. As that VVF is now emerging. In Limpopo now is worse, I think so. we have got genitourinary fistula, which are called obstetric fistula. It's better if we have got them from surgery, PH or cesarean section. That would be the skill of the surgeon, or from advanced cancer or radiotherapy. But obstetric fistula, because of difficult and prolonged labor, is unpardonable. Typical prolonged cephalopelvic disproportion leading to total incontinence. It's emerging in South Africa. And as I told that I learned this thing while still practicing as a specialist. And I had an opportunity to visit Hamlin Fistula Hospital in Addis Ababa. I was there when trained how to do vesicovaginal fistula surgery. In Addis Ababa, there is a hospital which is just a fistula hospital. It's called Hamlin in Ethiopia. There are a lot of women, they stay there, they are part of that hospital. Others are not operable, others are horrible, because there in Ethiopia, our rural areas, they are not clinic. Traditional midwives are the ones that are doing the delivery. If a woman cannot deliver, she develops a VVF. And the husbands, after the woman developed VVF, they abandoned that woman, so she was got nowhere to go. She go to Hamlin Hospital. Hamlin was a missionary who started that hospital. And they stay there. The whole world goes around, because the whole world, there are no much experience with VVF repair. The whole world, if they want to learn, like I did, they go to Ethiopia and go and learn how to do on those women. Because like Britain and Europe, you will never see that thing. If you want to learn it, you must come to Ethiopia and Hamlin Hospital. This is Mrs. Hamlin, the missionary who started the hospital, because of these women were male. And when you operate them, the skill is just good the skill, but it's not good to have. What brought them there is just poor health planning. And when you come there, because the country, Ethiopia, is not such much rich, each country sends its own people with the money and equipment and everything. Except when we were there, I was the only one from South Africa who didn't come with money. My government didn't give me any money to take there. I learned from Britain and other countries from money. When you come there, they know that help is coming. You can see from the eyes of those women that they are yearning for help, and help is coming. And I think we helped a lot of them. And if we don't turn around the situation in our country, we're going back to the situation like in Tanzania and Ethiopia, where we have got general vesicovaginal fistula, which is an abnormal opening between the bladder and the vagina that results in continuous unremitting urinary incontinence. Another form of incontinence that can occur because of that is between urethra and the vagina, or urethra and vagina. But VVF is the most common type of obstetric fistula that we have. And mind you, with VVF repair, the first repair is the first repair. If you don't repair the first time, the second repair is very poor. Like this, you'll find there's an opening between the bladder and the vagina, and the urine, instead of going through the urethra here, it leaks into the vagina and it comes out through the vagina continuously. These are just classification. It can come from the uterus to between the uterus and the bladder, which is called vesicouterine fistula, or number 2 is VVF, which is called vesicovaginal fistula, or fistula can occur between the rectum and the vagina, is called rectovaginal fistula, or it can be between the urethra and the vagina, which is called urethrovaginal fistula. But the commonest that we see nowadays is number 2, vesicovaginal fistula, which we should improve our health care system to avoid that. And the best method to diagnose it, if you suspect it, is what you call cystogram. With a cystogram, you can put a dye here and take an X-ray. This is the bladder, this is the vagina. You can see there's a connection between the X-ray, the bladder, and the vagina. And nowadays, with the MRI, they can delineate it very easily between the bladder and the vagina with magnetic resonance imaging. But the MRI is expensive. What predisposes people to VVF is poverty. Not individual poverty, national poverty. Not only national poverty of money, poverty of thoughts, mental poverty, by ineffective healthcare planning and women has got poor access to emergency obstetric care. And with the emergence of CPD, of teenage pregnancy, you've got a lot of cephalopelvic disproportion. And if the access to emergency obstetric services is poor, majority of women teenage pregnancy will end up with vaginal fistula. Another thing that, because this should be, some of the problems can be detected antenatally during antenatal care. If antenatal care attendance is poor under G, problems will not be detected. And they will only be discovered during delivery. And nurses are caught with their pants down there. Hence, you find that people have got vaginal fistula. Let's reflect back. What can discourage poor antenatal care attendance? I remember back some men that we must just applaud. Good rules, which are good rules, which help women. This man, he made a ruling while he was ruling that if any pregnant woman, every pregnant woman should attend a clinic. It's a rule from government. If you don't attend clinic, the donor or anybody must go to your, the woman is pregnant, is not having a clinic card. It was a rule that was made by sorry, a man with a vision. His name is Patrick Mpepu, a man who had good advisors who ruled. He made Venda into a tourist area by putting proper rules which function. I think now when we think, when things we see things deteriorating, we think of people like Patrick Mpepu, who the maternal mortality, infant mortality was low in Venda because of the rules that people put. People must be governed and rules must be put. Like, for example, you look at this one. Also, I worked in this area. That's why I say I never knew how to repair VVF because it was not there when I was working in Garankua.
We have got the strength, we've got the power. There is but nothing. I want to say, says plus Yama, go South Africa. How we put a John as a Sia. Redidimetse, Resa Chenyumutupe, Resa Rumalane, Resa Bui, Resa Palami Mohodi Muhammad, Rai Polela, Batu, Batlore Leza, Batu, Batilore Batla, Renale Tata, Fela Harka Charahana, Anke Kiwan Moholo Nabahai.
From this message, from his message, and 5 points. The first thing, ordinary matter, we've got the power. It's true. We've got the power to change the situation. We don't need somebody outside. Like he changed the situation. And number 2, he says, nothing will happen next door if the next door country is not all right. Like the same, we have the situation. We've got a problem in Zimbabwe, it affects us. He realized long ago that if Uganda is not all right, South Africa will not be all right. Now we cannot be all right if the next door country is not all right. And number 3 is it, he used not to be on Twitter and TV and other things. He doesn't do one thing and go and place himself and say, I'm going to open blah, blah. He just do things quiet. Number 4, important thing, if we can have a listening health planner who listens to advices from wise people, will be far. But people don't listen. Eh? When you tell them they don't listen, well, actually, if the advice is from the wrong color, from the white, they don't listen. They just do wrong things. And lastly, he says, unity is strength. There's nobody who can deny that unity is strength.
We have got the strength, we've got the power. There is but nothing. I want to say, says plus Yama, go South Africa. How we put a John as a Sia. Redidimetse, Resa Chenyumutupe, Resa Rumalane, Resa Bui, Resa Palami Mohodi Muhammad, Rai Polela, Batu, Batlore Leza, Batu, Batilore Batla, Renale Tata, Fela Harka Charahana, Anke Kiwan Moholo Nabahai.
You know, the unity is strength, you know. It's true, unity is strength. You cannot deny that. This year, he shows these people. He shows people who ran an effective healthcare system, effective education system, effective job creation system, under difficult conditions of apartheid. Why can't we do it now? Not in apartheid. And these people who realize these things now, it's Bantu Holomise, and he's telling the truth. These people, they ran an effective healthcare system under difficult conditions. I cannot talk too much about them because most of them I don't know much. By this time, education, health, justice were just number one. And as I polele, as I murmamato, as I ring, actually, I saying about him because he is the one who realized that we need nurses, we need doctors here. We need to send students to go and study and have doctors and nurses and specialists. I'm one of the beneficiaries of Chidi Tawia. He sent us there to go and study, come and help. That's why I always thank him and say, this is the man who contributed me and to the welfare and to the health of South Africa. If everybody can think like Chidi Tawia, Dr. CNN Party, this country will be fine. If this man was ruling now, if this man was a president of South Africa today, it would be a superpower, very much. Lastly, I want to talk about periurethral bulking agents, which I said are not much used. There are two types of bulking agents, macroplastic and bulkamid, and they are not much used as such, but they've got a place in frail patients, which I'll demonstrate to you how they use it. They put a bulking agent.
Macroplastic is an injectable soft tissue bulking agent. During the implantation procedure, 3 boluses of macroplastic are implanted in the submucosa of the urethral wall. These are referred to as the 6 o'clock, 10 o'clock, and 2 o'clock positions. Macroplastic is injected using a tunneling technique. This technique is accomplished by utilizing a 3-step approach. First, while keeping the needle bevel facing the urethral lumen, insert the needle to the first circumferential mark, or approximately 1/2 centimeter, into the mucosal lining at a 30 to 45 degree angle. Second, while maintaining this depth, reduce the needle angle to 0 degrees. Third, advance the needle to the second circumferential mark, or approximately another 1/2 centimeter, creating a tunnel in the submucosal space. It is important to use this tunneling technique to prevent an injection that is too superficial or one that is too deep.
By so doing, you are increasing the urethral closure pressure. So it's a strategy that I think we can use to manage urinary incontinence, to increase awareness, like in talks like this, and teaching on people about fluid intake, adaptation, care of the elderly. It's a mainstay. Avoid bladder stimulants like caffeine, avoid diuretics, constipation, empty bladder regularly 5 to 8 times a day, and to perform pelvic floor exercise. Those are the things that we should teach people so that they must know how to manage urinary incontinence. Nursing management, I don't mean my nurse. If you are looking after an elderly woman at home, you are a nurse. Encourage the patient to urinate at scheduled intervals. Like you used to arrest your baby who was bedwetting. And again, provide support, both psychological and mechanical support. If she can't stand up, pick her up, put her on a wheelchair. And lastly, teach her on what urination is, what bladder function is, which I think the knowledge you've got from this webinar. And if there's any woman who has got the same condition, bring them together, make a focus group so that she mustn't think she's alone in this condition. She must know that other people are like that. And in conclusion, I would like to say that we must reduce the social stigma that's attributed to it. urinary incontinence, more especially stigma that's attached to the elderly urinary incontinence women who have given childbirth. They are so stigmatized that even their own children sometimes they shun upon them as if they will never be women and have incontinence. You understand this thing is a aging process. Then medical complications that occur because of incontinence, like skin breakdown and increased urinary tract infection, treat them continuously. Don't send them to institutions like nursing home. Give them tender loving care. I repeat that it is wrong for any person to send his loved one to a nursing home. It's wrong. Look at this. Listen to this story.
A 30-year-old son decided to admit his father into an old people's home as desired by his wife. He brought the father in a car to an old people's home run by a Catholic priest. Then appeared this elderly priest who came out to have a long chat with the old man. The son wondered and asked the priest whether he knew his father before, since they were talking as though they knew each other. The priest replied yes and continued. He came here 30 years back and took with him a very sick orphan boy who everyone else had rejected for adoption. This man gave that boy home and saved his life. He told us this little boy deserves better. I'll dedicate my life to make him the wealthiest young man when he turns 25. The priest continued, I don't know how long you have known him, but I can tell you he is a good man, and I am glad to inform you that you were the sick boy. The boy, on hearing this, fell on his knees and begged the old man for forgiveness. The old man looked at him with a smile and said, Son, I have forgiven you. You threw me out of my own home because of your wife. Take the house, but know that I have removed you from my documents as the sole heir of my empire. I have willed all my properties to this orphanage where I now belong. This heartwarming tale serves as a powerful reminder. At the pinnacle of our success, we must never forget our roots. For if we do, we risk losing our way and relinquishing our crown. Let us always remember those who guided us to the top, for they are the unsung heroes of our journey.
I always get impressed in my rooms when I see people bringing a woman with incontinence. They come, all of them, daughter-in-law, the daughters, all friends, they come and they, even in the waiting room, you see that they care for this woman. This is psychological support that the woman needs. And the treatment success is explained to them. There's different, sometimes treatment success is subjective in incontinence, where the woman is cured, is symptoms-free. In incontinence, usually, we talk of the patient no longer needs many pads. We talk about improvement. We can only be improved, but there's no total cure as such. It's when the subjective assessment of the condition by the patient is that she can live a better life. That's what we are aiming at. Because there shouldn't be limitation in physical activities. Women has got a lot of physical activity. A woman with incontinence, if treated well, you can participate in activities. Experience that I'll tell you. I treated a woman and I went to a wedding. I didn't know that woman is singing the song called Step. And I saw her throwing her legs and the body. This woman is no longer incontinent after treatment because treatment is so successful.
Thank you.
very much for listening to me. This is the end. I hope I've enlightened you a little bit on stress urinary incontinence and agency incontinence. Very huge topic. I think with this, I've shed some light on you. We can open for questions. Let me just allow you to unmute yourself. I think I've allowed you to unmute yourself. You can raise up your hand. And if you raise up your hand, I can see you that you've raised your hand. Then you can ask a question or clarification or addition. Do you know how to raise your hand? Somebody's laughing. Away pet 4 P4 lead. Away P40. It's not your name here, it's Away P40. Your hand is up. Talk.
Hand is raised. Raise up hand. Reaction.
Anybody with a question can ask.
Hello.
Hello?
Hello.
Hello. Komuto Mazoro's hand is up. Komuto Mazoro, your hand is up. Just unmute your microphone and talk.
Thank you very much. Thank you very much. I would like to thank you very much for the presentation. Really, it has opened us a lot. Thank you very much.
Thank you very much, my brother. And who you have got your hands up, unmute your microphone and talk.
Thank you, Dr. Mahapa, for a wonderful presentation. A number of people that we had shared were not able to join. Are you likely to offer another similar presentation or other means that other people might be able to access this very, very useful information? Thank you.
I must apologize. You know, it's historical. My Zoom, I upgraded only to take 100 people because all along my presentation, I never reached 100. This one, I was just alerted by Dr. Mutlanti, who is one of my colleagues, who could not enter in. But I've exceeded the threshold of my Zoom. Once you reach 100 people, could not accommodate other people. So I've got an alternative. I have to repeat this talk, but not in the near future, maybe early next year. But I have to upgrade my Zoom to another version. You know, Zoom works this way. The free one, you can only join 10 people. The one that you pay, there's this one, I think they call it professional, this one. It takes 100. There's one called industrial. I think it takes 1,000. I think I'll have to buy industrial package. I apologize, 1,000 apology for this. I never thought people would reach 100 because I've never had more than 100 audience. There you were 100, and that's a straight. Sorry, Malebu, I'll have to repeat this one. So
Hello?
managed to enter.
Sorry, hello?
Hello. Hello.
Yeah.
Can you hear me?
Oh, somebody's
wait,
talking.
wait, let Solim Planti talk, then from there Sali will talk.
Thanks, Dr. Mahapa, for this very important, topic because, women, all women hide this and think that this is a normal aging problem. So it's very important to tell people, make them aware that no, urinary incontinence is not an aging problem. So that people can know that there are treatments, for this condition. They don't have to hide and live with this terrible, demeaning, situation. One thing which, got me very angry is what you said about the vaginal, fistula.
VVF.
I mean,
VVF.
that's a shame to the profession in Africa itself. I mean, to allow such things to happen at our continent, it's terrible. I'm just ashamed of myself to hear that there are women who stay at the hospital because of such a thing. And the thing is coming to South Africa. When Prof Mokokong used to teach us, he used to take us to Venda, Gazankulu. Prof said gynecology obstetrics is not at the tertiary hospital. It's right there at the village in the clinic. So students should be taken there, you know, to this rural clinic, like the Venda clinic we used to do and Angampepe and whoever. Nurses must never be taught at universities. They must go and be taught next to hospital, even rural hospital, where they can take, you know, maybe a month or two at those areas to teach, help work with the nurses, impart knowledge to these nurses, so that we shouldn't have this kind of fistula, where people go there and learn how to repair them. The last thing which I might have missed,
more than you.
Yeah, the last thing which I've missed might have been the cotton wool test. Thank you.
Thank you very much. You see, this is Dr. Mutante is becoming emotional about it. It really disturbs the mind of any doctor. Sally?
Oh, good evening, doctor. As a nurse clinician, I've learned a lot, doctor. As a nurse clinician working in a primary healthcare setup, I've learned a lot. I would know how to manage the patients, especially with non-drug management. Thank you so much, doctor. Hope to have a talk next time. Thanks, doctor.
Yeah, thank you. Matabu, unmute.
Good evening, doctor. Hello, doctor. Can you hear me?
I can hear you, my darling.
Okay. First of all, how do we get your webinars? Because this I just got from Facebook. Many people were sharing, and I was like, where did they get this? So this is the first time that I listened to your webinar, and I would like to listen to you.
On the Facebook, that's where many people get it, and they share it among one another.
Oh, okay. Okay,
Yeah,
so I must just check your Facebook page.
Yeah, those who are my patients, I've got a database, I send them directly. And some people who are on my phone, I send them. That's the only way I distribute it. You just hand to hand. Probably people told another person. I didn't send to more than 100 people, but I've got 100 people here.
It's circulated a lot. I think you should do the 1,000.
Okay, I think this one, I'm going to make it and put it on a YouTube, this presentation.
Thank you so much. And just one last one question. In the primary healthcare in clinics, do nurses, if you take an older person to the clinics, can the nurses help there, or do we have to go to doctors and all that?
I think they can help. Initially, this was called primary health care, with hygiene, education, looking after pampers, how to look at people at the elderly one that you cannot even operate, you can't go to the tertiary institute. There are people that are not fit for operation. They need primary health care in treating other minor ailments like urinary tract infection, skin abrasion, teaching the family how to look after the pampers, teach them the method, and all those things. Like things like Kegel exercises, as things that are taught by midwives at the clinic after delivery. There is a place for primary health care physician to start there at the primary health care. There's the need to elevate it to the hospital. And probably the nurses are trained enough to see which one must be elevated, which one can be managed here.
Okay, thank you so much, Dr. God bless.
God bless. Nessa Tendi, Nessa Tindi. Nessa?
Thank you. Yes, doctor, thank you so much for the presentation. It was very informative. I just want to ask, because recently my mother has been having some episodes like she's getting stroke, her legs will be weak, and it will be like she's confused at some point. And then she went to a urologist, and then they said they did a biopsy because there was a growth on the urethral tube. So they said it's a urethral mass. So now she's on a treatment of a cream, Aldara cream. So I want to know, after the 6 weeks, those warts will be gone and they will not cause cancer. I just want to know. there,
It's
Doctor?
unlike, you once used to mention Aldara. Aldara is the treatment is antimitotic treatment for viral warts. Probably that mess was caused by a virus, usually human papilloma virus. And you know, human papilloma virus, there are a lot of strains for it. And usually those that forms warts, luckily they don't form cancers. Cancer that is the type of warts or viruses that only forms warts. And it's treated with Aldara. They did surgery in Aldara. The probability that should have cancer are very minimal, if not non-existent. I'll say don't worry much about cancer.
Wow, thank you so much.
Teresa, unmute. Okay, Teresa is just raised up his hand, but he doesn't hear what I'm saying. Ladies and gentlemen, thank you very much. You remember, and previously, 5 months back, I made a presentation on pelvic organ prolapse. And thereafter, I got so much, people said I must repeat it. I deliberately refused to repeat it immediately. And I said, I'll repeat it before I retire for December. December, there won't be any webinar. This webinar, monthly webinars. I'll run 11 months webinar in 11 months, 11 webinars. December, I also want to rest. So next month, I'll repeat the pelvic organ prolapse, probably in a different fashion. It will not be the same as it was before. It will either be better or worse, but I'm going to change it. So I'll send the webinar as it is, but I hope by then I'll have upgraded my Zoom to accommodate at least 1,000 people. Thank you very much, ladies and gentlemen. This will be on Facebook as a link, and I'll put it on YouTube because I don't think this one, the YouTube will reject it out. It will accept it. Thank you very much, ladies and gentlemen. Thank you. Let's close.
Thank you, Doctor. I wanted to unmute myself, but I was struggling.
Who is that?
But
Who is
Teresa.
that? Oh, Teresa, how are you?
Teresa.
Yes,
I'm
Teresa.
good. How are you?
Fine.
I was just struggling a little bit. No, I was asking about the very thing you have just mentioned of the prolapses, because I have a relative whom they said she's having posterior pelvic prolapse. Because we were thinking maybe he's having uterine prolapse, but they said
When they say posterior pelvic prolapse is a rectum that prolapses, is a rectocele, which can be quite a treatable condition. It's quite a treatable condition.
Oh, okay.
I think if they made the right
Surgical
diagnosis, they can do the right treatment.
Okay.
Thank you.
Thank you so much. It was very, very, very important.
Thank you. Bye. Bye. Good night.
We appreciate it.
Good night. Mahapa, good night.
Good night.
It's Dr. Sepan, Dr. Mashiko.
Oh, thanks, my friend.
Bye.
I'm
Thank
just
you very
seeing here
much.
who
Bye,
was
Dr.
here
Mahapa.
all along. Thank you very much, my dear.
Bye, Doctor. Thank you so
There's
much.
a little baby at home.
Bye, Doctor.
Thank you.
Welcome.
Thanks, Doc.